Okay, now we're gonna do bones of the extremities. How was that quiz? That quiz, was it hard? Hard. Haha, my stuff. I like this stuff. So I'm gonna try to explain to you as much as I can. Let's go through it. All right, guys, listen up. What the heck are those people doing? It's the guide table. They always have to experiment. Now that the bones of the trunk are discussed, let's go to the arms and legs. The shoulder girdle starts with the shoulder blade and the collarbone. What are the anatomical terms of those two? Sternum and scapula. No, wait. Collarbone, clavicle, and scapula. So that's the other thing, guys. If you want to have full value on the quiz, which counts for the grade, my money, your grade. When we go through these, you get the correct answers, and if you haven't done the quiz fully correct, get all the full points, you go after it, over it, and do it, and get all the damn points. If you come to me, it's like, oh, no, look at this quiz and go like, because this all, I'm giving you everything, it's all busy work at the end. You just have to do it ahead of time too, and I know some of that is hard work, but it slows everybody down a little bit by having to read these questions. I know. But that's why I did them, so we're slowing down a little bit. So, collarbone is clavicle, shoulder blade is scapula, and those two anchor into the shoulder. All right? When we look at I'm going to talk about these. I like this picture a lot because it shows emotion. So when you lift up your arm, your shoulder blade is actually doing a lot of the motion there too. We don't need to think about that, right? But that shows you that. And then here we show a bunch of the muscles because I want you to get a framework idea that this upper extremity goes into the trunk and is attached by a joint only here. Everything else is muscle. Thank you, guys. Take it outside if we're going to talk about it. All right? Thanks. Yes, the only joint is right here that attaches the whole upper extremities to the trunk. Everything else is muscle. So we then have muscles. When we talk about the muscles, we're going to have muscles that hold the shoulder blade to the trunk, and then we're going to have muscles that hold the arm into the shoulder blade. And so when we go next week and talk about that, we'll talk about those pieces. Yes?
What's the joint called again?
The joint here is called this is the sternum. You talked about that, right? Sternum. This is the clavicle, so they call this joint the sternal clavicular joint. They always name the joints by the bones that make the joint. That's very good. Yeah. So if you know the parts of the bone, sometimes it's not the full bone, sometimes it's a part of the bone. Like in the hip. It's not called sacro-hip joint. It's called sacro-iliac joint because this part is the ilium, and we talk about that in a minute. Yeah.
So that kind of helps you.
Oh, it makes everything much easier because once you have these consistencies that you can sort of rely on, even if there is a few exceptions, then it makes more sense. It's not, if it's just linear think, it's very difficult to not get overwhelmed.
Oh, maybe I didn't hear you right. Last week, did you say something about cartilage going together? We were talking about the socket.
The who?
I don't. Maybe it's in my head.
The cartilage at the end of bones. The cartilage is at the end of bones, so the bone don't go bone on bone.
Right.
But holding the bone into two bones together is a joint capsule, and then ligaments, and then muscles and tendons.
Because the muscles surround it, but okay.
Well, they move it. Yeah. No. They move it.
But the muscles are on the bones, right? Or maybe it's, I don't know.
No, the ligaments will hold the bones together. But that's the thing. And then when it comes to pain, like shoulder pain, for example, I put some pictures in that sort of give you some ideas. But where I go with, and we just had a very interesting example with that, pain and function are related. So if you improve the function, so what we learn here is what's normal, what it's supposed to look like. If you know that, and for example, you got a bunch of muscles that attach here from back here and grab the shoulder. And if you have a dislocated shoulder, you know these are going to be elongated. So you know that's going to be a problem. Even if you can't necessarily name what the pathology is, if you go and talk to a doctor, you have the framework to say, well, this is probably what's going to happen. Can you help me figure out what to do about that? You know, so that's why I want you to understand as much as possible from the practical aspect. All right, so let's see. If you reach your hand on the opposite shoulder, your palm is touching the trapezius muscle, your fingertips are likely resting on something harder, a ridge that goes across. That ridge is called the spine of the scapula. Above as well as below there we have a shallow depression. A shallow depression always, or a very good word for it, it's not always, but a very good word for it is fossa. All right, so what we do right now is we reach over the opposite side of the shoulder. It's not so flexible here, it's an old person. And then we touch the spine of the scapula, and then above it is the fossa, below it is the fossa. Supraspinous fossa, infraspinous fossa, because the spine is the reference point. And then, what are the parts? Oh, I just said it. You got it right there. So the one above is the supra, and the one below is the infra. And on the picture, is right here. That, if you see that on the picture, it's the back. It's from the back, posterior view. Spine of the scapula, supra, and infraspinous fossa. And then we're gonna put the finger back on a, follow it to the tip of the shoulder. If you widen as it gets bony, that place is where, wait, if you finger back onto the spine, the scapula, follow it to the shoulder, you can feel how it widens and gets more all bony. That's right here, the tip of the shoulder. What is the place where the collarbone also comes in and forms a joint with the scapula? What is that called? The acromion. Good, acromion. So right here, that's the acromion. The tip of your shoulder is the acromion. Like if I, at the office, if I palpate somebody and I feel the tip of the shoulder, I go down, if the arm doesn't align, if it's too far forward, and I feel a big gap here and a bump here, I'm like, oh, something's wrong with that. And it's usually forward, so we have to push it back somehow. And sometimes that's all you gotta do. Sometimes it doesn't hold, but that's the first step, looking at that stuff. Yeah, well, I'm always amazed how much it helps, actually, or how often it helps. Oh, that's a long text. So now I want you to pull your hand over the front of the shoulder, opposite side. Looks, you likely feel a rounding in the palm of your hand. At the top upper bone is where it attaches to the scapula. So the rounding is right here. All right. On the thumb side, which is the medial side right next to it, you feel a bump that hurts if you press hard into it. Right there, that bump. It hurts if you press hard into it. You can also find it by feeling the soft area just below the collarbone right in here and moving laterally to the outside until you hit a bone that sticks out a little bit. That process in the front of the scapula is a great attachment with multiple muscle that helps stabilize the shoulder blade and move the arm a little bit. Can you name what that bump's called? Huh? The coracoid process. So I always think it's like the raven sitting on the witch. It says coracoid, coracoid, and so then it's right there. And it took me a long time to learn how to palpate that. And it's really like you go on the shoulder and you go right medial and there's a bump deep and you poke it, it hurts. And the muscles attached will go like here and into the arm a little bit. And so there's a bunch of muscles there. There we go. And on the spine, on the picture you see it right here. And on the next picture, that's the frontal view, you see it right here. Yeah, that's a good bone. Oh, this gets the upper arm bone. What is the anatomical name of that? Humerus. Yes, the upper arm bone is the humerus. That has nothing to do with humor, but it is called the humerus. On the top round thing, the head of the humerus, joins the shallow part on the lateral side of the scapula and the glenoid cavity. Right where the rounding stops is known as the neck of the humerus, like in us, the neck is below, well, below the head is the neck. Then below that in the front are two poo bumps that are muscle attachments. What are those called? Anybody? Yes, greater and lesser tubercle. So the bumps, all right, if you look at your model on the table, you got, oh, I got one here, by the way. The bumps is a right arm that you got on the table. The bumps are on the outside. There's one here, a bit bigger, and then there's a groove, a depression, and then in the front there's another bump, a smaller bump. The bigger one is the greater tubercle, the smaller one is the lesser tubercle. In some books it still says tuberosity, but a tuberosity is a big bump and a tubercle is a small bump. Good, we can go right ahead. Run your fingers in the front of your shoulder down to the side of the upper arm. You likely feel a muscle that's surrounded on the top and narrows down and comes mid-humeral level. If you press hard, that bump probably hurts a little bit because it's a muscle attachment. So that's right here. You feel it go down, you feel a bump about in this section right there. It's where it hurts, that's where the muscle goes into the bone. And that's, you know, that muscle pulls on the bone a little bit. Right here, what is that called? Deltoid Tuberosity. Yeah, see here we use the term tuberosity. Now run your fingers and thumb down towards the elbow on both sides, the inside and the outside. You feel that the humerus widens towards its end, especially on the inside. Right in here, you can feel when you go like that, you can put your, you can put your thumb like that. We're going to do that when we do muscles. We're going to go in like that and hold the fingers down. And what are the muscles called? We're going to learn it that way. So what is that bump called here? Epicondyle. I know you guys are afraid of the term. You just speak it out the way you want. So there's no wrong in that anatomical terminology. I know, I'm from Switzerland, so we learn gazillion languages we have to learn. Like you start with High German, and then you got to learn friggin' French, and then you get to speak, English maybe. And then you speak Franglish, German Franglish. But one of the things you realize is you just say the words. You're not, in America we don't learn that many languages, so we get afraid of speaking it wrong. You just speak it out. It's gonna be all right. In anatomical terms, there's so many different ways of pronouncing it. You're most likely are not wrong. If you feel the tip of your elbow, you're actually touching the top end of one of the forearm bones that runs parallel towards the wrist on one inside and the outside. Can you name the two bones that make up the forearm? Ulna and radius. Let's talk about the pictures a little bit. We jumped a bit fast here. So we got the humerus here, which is the head and the neck, and then the greater and lesser tubercle. The other thing you need to know about the humerus, listen up, is you have a neck up here, right underneath the rounding, where it stops. That's called the anatomical neck. And then as you go past the bumps, it narrows down, and that's known as the surgical neck. And the reason why that's the surgical neck is because if you break it here. You don't break it here. It's the weaker link. So if they have to do surgery, they do it here. So, most likely they have to do it here. And then you go down, this is the outside, deltoid tuberosity. And as you get narrower, you have the epicondyles. Now in anatomy terms, a condyle is something that makes a joint. An epi is above something, whatever you describe it. So an epicondyle is above the condyle. A condyle makes the joint, an epicondyle is above it, and that's where we have muscle attachments. In the knee, it's going to be very nice, because here we have, these are all different names. We don't learn all these names. All right? But that's where the term epicondyle comes from. All right? Like we have mandibular condyle, makes a joint. A condyle makes a joint. So that's also good to know. All right, so that was that, and then we did the elbow. And what we need about the elbow? We need the tip of the elbow. The tip is the back. So this piece here, oops, that's the tip of the elbow. So that's like right in here. All right, that's the forearm bone. That's the ulna. And so that's right here. That's the ulna, and then outside that's the radius. And on the radius, we got the round thing on top. That's the head of the radius. So when you look at your arm bone here, that's a round. It's really round up here. I mean, there is the thing. This joint here turns around when we pronate supinate, arm palm up and down. And then there is a ligament right around here at the bottom of the head of the radius, and if you yank a forearm really hard, that pulls over, and they call that the nursemaid's elbow, because in the kids the stuff is looser. And so the nursemaid's elbow is when the nurse, the maid goes like, "Come on, kid, let's go to the park," and it yanks out the forearm. Then they can't move it. It's like hurts like hell, and everybody's freaking out. And the motion is, you push it back like that, so it goes hopefully back over where the ligament is over the head. So that's, how I remember that part. I think the head is on the. Yeah, the head is on the list, and then the radial tuberosity, and the neck of the radius, and then the styloid. So let's make sure you've got the head here, and then the neck here, and then the tuberosity here. So under the radius, you got these terms that you want to know. They're right on top. And the test is with the models like that, not the single bones. The models are all attached for the test, okay? So that's what you want to know. Then the other term you want to know, if you go below at the bottom, you have the styloid process. So if you feel like here, there's bumps, that's actually on the thumb side, and that's on the pinky side. So right here where it bends, that's the end of those forearm bones, and there's a little tip here, that's the styloid process, and on the other side is right in here. All right? It's right here, and then right here. And see, that interesting thing is that makes this sort of a rounding like that. And so the whole wrist sort of sits in this shallow depression here, and you got these wrists, these carpal bones, you got a row here, and then a row here. And then they can sort of transmit the motion that you can do this and you can do this. Because with this shallowness, you can do this motion. So that's kind of cool. All right, and then it goes into the metacarpals. But let's see, we probably have a question on that. That's ulnar radius. Your wrist bends where the carpal bones are found. These bones are. There's a lot of them. They're a small area that holds a bunch of small-looking bones. 8 of them, with difficult names like hamate and pisiform and trapezoid, and very funny name. They are the junction between the forearm and the hand. The web of your hand is made up of metacarpals. How many of them do we have in each hand? 5. So the carpals are here in the wrist. The metacarpals are the web of the hand. Even they look like fingers, there is in between stuff. So the fingers are the ones on top. All right. Fingers are quite remarkable. They are composed of phalanges. 1, 2, 3 phalanges. 1, 2, 3. Even the pinky has 1, 2, 3. But the thumb, how many does the thumb have? 2. So even the thumb is the big puppy. The thumb can do this, and then this. The finger can do more bending. Has 3 segments, not 2 segments. So that's good to know. Potentially. There was those bumps. See here, they're all listed, but you don't need to worry about studying those. But it's interesting functionally how they work. I mean, it's very intricate. I mean, it's remarkable how the body works. All right, coolio. So let's go to the leg. With that, next, right to the legs. Well, the pelvis first. Remember, the sacrum is the end of the spine. On each side attached, just a big roundish kind of flat bone. The 2 of them meet in front below the stomach, right here. Put your hands on each side of the ridge of the bone. It's where you can conveniently carry a baby. Can you name that part of the pelvis? That's the crest. Iliac crest. In actuality, each pelvic hemisphere is made up of 3 bones that fuse together. The ilium, the ischium, and the pubis. That's like a cartoon or something. What names are those, right? You can see them in different colors in the picture that shows the bones from the side. The ilium on the top is the largest portion. It connects to the spine on either side of the sacrum. Now, can you name that joint? Ilium to sacrum. Or sacrum to ilium. Sacro-iliac joint. That's how you name it together, the joints. That's why I put it in. Putting your hand back onto the iliac crest, feel your fingers towards the back until you find a distinct bump. That's right here. An abrupt finish to the crest of the crest. Now, look at the picture that shows the bone from the side. What bumps are your fingers feeling? Posterior, superior iliac spine, correct. Good. Make sure you do the quizzes before class. When I look today, an hour before class, half the class hasn't done it. Bad sign. Because you really want to watch these videos and do the quiz a couple days ahead of the game. And then the material can be a little marinating in your brain cells. Because if you only do it when you're right before class or even in class, because I still had like 5 or 6 that didn't do it. See, I could even look who it is. I can come with you. I can push the button and it says it's this and this person. But if then it's overwhelming. It's much more overwhelming. So ideally you do the quiz. You finish the quiz the day before the class. That's, I think, ideal. You don't worry about the stuff before we come to class, and then we got a good session here. But anyway, that's my spiel there. So posterior, superior iliac spine. If you're sitting down, I want you to rock from side to side a little bit and feel your sit bones. You should actually be sitting and balancing on your spine wait a minute. You should actually be sitting and balancing your spine on them when you sit instead of what most of us do, which is slouch and put the extra pressure on the lumbar part of the spine like that. What is the anatomical term for the sit bone? Ischial tuberosity. This is a good one. A lot of people say ischial or ischial, so it doesn't matter. Both of them. Ischial tuberosity. That's your sit bone. So let's go look at some of these parts. There we go. PSIS, crest. Oh, there, crest. Goes all the way to the back and then all the way to the front. Here we have the anterior superior iliac spine, or as is, like in IKEA. Is the best section to go look at, an as is section. As is. And then I don't think we worry about that. But we don't worry about that term, we don't worry about that term, I don't think. But here's the ischial tuberosity right here, the big bone. All right, some of these smaller terms I'm not going to worry about. In front, right below the stomach, can you feel the bar of bones? It is actually a joint on it. Can you name the part of it? Can you name which part of the pelvis that is? Pubic symphysis. So let's go to that. Right here, the pubic symphysis is actually the actual joint. So you got a disc in here, same as discs you have in the spine. Between vertebrae, you got these intervertebral discs. You got one here too in the front. So sometimes if you squeeze your knees together, or put a wrist and squeeze your knees together, like when you're laying down and they have bent a little, or you got them up, you get a little crack in it. You can feel a little pop. You can release some tension. So that could be helpful, depending on what's going on. That's an adjustment right there. The thigh bone, okay, let's make sure we got all the terms on the pelvis going. Don't miss anything on there. Crest, acetabulum, auricular surface. Oh, you can cut that out. Auricular surface, we can take that term out. You see that there on the term list? The third term at the bottom of the second column, just take that out.
Which one?
Auricular surface. Yeah, I'm not gonna worry about that. But we also got acetabulum. The acetabulum is where the thigh bone fit in. So that's right here. That's that shallow. Well, it's not shallow really there. It's pretty deep. But that's why this stuff is so stable. It's much deeper than we have it up here. Iliac fossa. You can cut that out too. The next one, iliac fossa. Ischial tuberosity is clear, we should keep that, and symphysis pubis is clear, we keep that. All right, perfect. Now let's go to the next bone. Thigh bone has a round head that fits nicely into the pelvis. Can you name the oh, yeah, that was the question. Which one? The acetabulum. Acetabulum, like I guess acetone for the fingernails or so. If you palpate your hips, pushing from the side to the top of the thigh, you will feel a hard, plump, rounded structure. It's a bony prominence that serves as a sign of many muscles to attach. Some that prevent your pelvis from falling over when you lift one leg. We'll talk about that. And others that turn the foot out. So we're talking here, right? We're talking right here. That's the big bump. What is that big bump called? Greater trochanter. Good. Is that on there? That's the big bump. There's another one, a small bump. That's this one. What's that called? Lesser trochanter. When you look at the muscles that attach, so if you got a big bump, you got to think muscle attachments. Why else would the body do this? This is where it's like you got to ask the question, why would you do this to the body, and then or to the God or whoever you want to talk to? But if you think here, you can have muscles that attach here, from here going into here. And if you stand on one leg, the muscle go from here to here. You stand on one leg, and if this muscle doesn't contract, what happens is going to be this. My hip is going to fall down. If this muscle contracts, it's going to keep the hip up. So that's a good muscle to have. Then the other muscle that's really cool, another one is going from in here to out here. And so when you contract that from here to here, you turn the leg out. So if you turn your foot out, the motion is actually up there. So that's another good place we can have muscles attached for that. So the walking and then the foot out. That was for that. Good. Greater trochanter. Then I want you to reach in the back of your thighs while you're sitting. You got to sit. You can do that. Reach your back of the thigh, and you will feel a muscle on either side. If you press deep with your fingers, you feel the back of the femur. Up and down, and the back is a rough line which serves as a tremendous muscle attachment side. For many of the quads, which are the front muscles, actually are attached to the back of the thigh here, and then they reach around and they attach down here to straighten out the leg. So they're really big muscles. Muscles reach medially from down in here to the pubic bone or the sit bone, then they do this motion. They bring the thigh inward. So if you think of what muscles do, where muscles attach and what they do, you always think, what happens when we bring these bones together? Or it's the easiest is in the arm, from here to here. What happens when that shortens? Muscles just shortens. From here to here, what happens when that shortens? It brings the leg in. What is it called? Linea aspera, and that's such a beautiful name. You know it's going to be on the test, right? You can just bet yourself. See, that is the second of the 5 I'm going to give you. You didn't even listen. Hello. This is also interesting. Here you can see the difference of male-female in the body at birth. The pelvis, the male pelvis is narrow, the female is wide. Because you got to make sure there's birth canal stuff. So what they do is they look here, and if this angle is less than 90, we're thinking it's a male pelvis. If it's more than 90, we're thinking it's a female pelvis. And in anatomy, it's really funny. They have this. They turn it upside down, and then it's a champagne glass appearance, and this is a martini glass appearance. Radiographic terms are very, very funny. So some of them you have to just laugh about. So that's one of the ways you can differentiate a male and a female pelvis, and that's the place in the body where we are different from the bony structures like that per se. We have a few other parts. And then, of course, the rest is testosterone makes the bone strong, firmer, and ligaments stronger, and there's a few of those things that are different between male and female. That if you're trans, you got to know about that. I mean, I had a patient who was trans male and was the drummer and hurt himself all the time, and at some point I'm I'm like, you know, your bones and joints are born in estrogen, not in testosterone. That's a different structure. You got to be careful how you behave with that, and you have to adapt to knowing that. It's like, oh my God, nobody ever told me about that. It's like, really? They did all this medical stuff and they don't tell you about this kind of stuff? Well, I know. Education, education. So, now, look at that, 20, we're doing pretty good. Now let's grab your knee with the fingers and circle around the kneecap. The patella, that is. If your knee is bent and relaxed, you can feel the distal end of your femur as you run your fingers deep next to the patella. What are these bumps called that you feel here on the side? Medial and lateral condyles. So that's a condyle here is really these two big bumps that make the knee joint. And they're at the ends of the femur, and then at the ends of the tibia, we also have these two bumps that also make the knee joint. We also call those condyles. The femoral condyle, tibial condyle. And then they make the knee joint, and guess what? Then above it, we got epicondyles. So that's how that word comes together. So in the knee, that's a pretty good way of making the word. All right. The knee is interesting. The top end of the tibia, your shin bone, is a plateau. The two ends of the femur, one on either side of the patella, curve from front to back. When you bend the knee, they roll on the plateau. Put two plastic-like round wedges of cartilage guide the movement. What are those hard cartilages called? Meniscus. The two menisci. So, I think this is important to appreciate because this is pretty cool. You can see which muscles are used in which part of the walk. So I thought that was a pretty neat picture. This is important. So when you look at this model, this is wrong. The knee doesn't do this. The knee actually more like does this. So the upper bone rounds on the knee plateau, on lower leg plateau, when it bends. So it doesn't roll like the hinge is not back here and it closes and opens both up. The top rolls on it. And you have these cartilage type structures on the inside that glide in that motion. And then you got different ligaments, and we're going to talk about those a little bit. No, we do that right now. You got different ligaments that hold the knee together, that hold the femur and the tibia together. We got two in the middle. They're called the cruciate ligaments. You heard of ACL tear, probably, right? Intercruciate ligament tear. So they go like that. One goes from the back to the front, and the other one from the front to the back, and they cross over. That's why they call cruciate, because they cross like a cross. Cruciate means cross. And then we got two on the outside. Two on the outside of the knee. One on the medial and one lateral. They hold the knee together that way. And then that all holds it, and then the muscles move it. All right? And so very often what happens is we have some injury, the meniscus tears, and that hurts like hell. And we have to understand what that means. If it breaks up and is part of the motion and it gets caught, you might have to take it out. But that's how a knee functions and is structurally kind of put together. Does that make some sense? Good. And most importantly, I think, is that we understand it's a rolling motion. It's not a bending motion, really, even though it's called a hinge joint. They didn't know that back then. Maybe. All right, so that's good. That's the meniscus. And then under the knee, in front, is a bump on the bone. It is attachment side for the massive quad in front of your thigh. These are the strongest muscles we have in the body. They have to hold us up whenever we stand upright by straightening our knees. Can you name the bump? Tibial tuberosity is the bump here in the front. You feel it. If you go down with your fingers, you feel it right here. Or on the bone, it's right here. It's that bump. That's where these muscles go in. And you often get, I don't know if anybody knows Oscar Schlatter's or tibial tendonitis. The boys, especially the boys, teenage boys, they run. These quads get really big and big and big. They pull on the bone, and the attachment side where they yank on the bone has to respond, and it makes more bone. Then the bone gets bigger, gets inflamed, and then the boys have to stop running around. And that doesn't fly. But that's what they say. And so the one technique that I picked up along the way that I've mentioned before that I think is fantastic, and I just did it on somebody who's got some knee pain. I'm like, I don't know what to do with him. I mean, you know, I try different things, but it doesn't necessarily need to be adjusted or anything. It's not crooked. So I take the palm of my hand and I massage from above down towards the knee. And then whatever pulls down here, it gets a little more room. That's the logic of it. And that's a high-end technique to get rid of Osgood-Schlatter's much faster than the medical, the way we have it, and it's from an Australian physical therapist named Strickland. Funny name. The Strickland method. And so that's one that you want to apply if you have somebody that's suffering, because it's very simple. It's very, very simple. Anyway, that's the tibial tuberosity. And then the outside leg bone is the fibula. It doesn't bear much weight, but it helps us absorb shock and stabilize the body from falling and collapsing to the outside. That makes sense, right? It kind of holds this outside stabilized a little bit. A thick ligament like a fascia structure firmly holds the tibia and the fibula together. What is that called? That one? The interosseous membrane. So in between here, you got a thick band or a thick connection site. Let's see if we can visualize it. Right there, this thing. And one thing that happens when you walk, and the reason why I want to bring it up is when you walk, the shock goes up and this bone moves up slightly and gives a little bit. But since these are really nicely put together, that's a nice little motion. It's a little springy. Yeah. If I do basketball, for example, or other things that make a lot of jumping, it wears out and it gets looser. This gets looser. A lot of tension gets created, and then the muscles in here, we get shin splints. Because we got posterior, we got muscles in the back, on the side and on the inside, deep. They're all pockets. They're all wrapped in thick envelopes. And then surgically, if it's really, 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 really bad, and they're worried that the muscle's choked off and dies, they cut the sleeve and the muscle expands. But a lot of the muscle force comes from pushing out against those envelopes, those fascial connections. And so that's another one of those surgeries that is like, let's try that last. Let's try other things first. And so one of the things I do is I put these back together. There's a tip strap that we have that holds this together. It's just a firm band that holds it together up here, so it cannot, when you walk, it cannot separate as easy. Then, you know, that's the issue. Sometimes, some places in the body, you know, you can do a lot without bracing, but some places it helps sometimes to be a little supportive with the brace, because gravity is just a lot of work. Like the feet, if you don't have an arch, you might want to have inserts to hold you up a little bit on that arch, so you're not just flat feet all the time.
So like when I exercise, nothing on me hurts except the shins of the front of my leg.
Yeah, that gets very, very stiffy.
It feels like you can't really stretch a bone, but like I guess you can. So like when I do at home, instead of sitting on the couch, I sit on it just to stretch it.
Yeah, you could do that. I often find, we're going to get to that next. Yeah, we got, well, I mean, stretching it down stretches all these in the front. That's cool. Stretching it up. We're going to get into the muscles. This motion, this is stiffy on a lot of people. When we do an evaluation for quantifying, we do that in here. The quantifying functional capacity stuff. So how many squats can you do? That tells you about these strengths. But another one we want to test is how much flexibility you got in your hammies, and also how much flexibility you got in your calves, because if these are stiff, you're much more prone to get injuries, because the whole chain from here goes up here, goes into the back, and all of a sudden it pulls on the back and you get back pain. So those are all the connections that sort of, we'll test some of those things out. So it kind of makes it interesting. And the other thing that I find a lot is, let's go to the next bone. Distally, both tibia and fibula widen and embrace the ankle bone. What are the bumps on the side of the two legs called? Malleolus. Medial lateral malleolus. That's when you bicycle. Have you done that bicycle and you slam that on the inside? It really hurts. You have nothing there. It's just bone and then skin on top. That's why it hurts
Is
so
that
much.
like the shopper cart that hits you in the back of the leg?
The who?
Is that where the shopper cart hits you?
The who? The shock?
You know, you're shopping and somebody hits you in the back of the car?
No, that's the Achilles.
Okay.
That's the Achilles in the back. That really hurts. When you walk and lift your one leg up, all the weight of your body comes down on the other leg through the top of the ankle bone and gets distributed towards the back, and where we have a heel bone, and the front, where we ideally have multiple bones in a row, making two arches that absorb the shock. So we have an arch. We have arches in the bone, and we have an arch here in the middle that goes up like that, and that like bounces nice. And then we got an arch here in the front that goes that way. That's this one, because if that arch is down, you got plantar fasciitis. You got these bones pushing down. That hurts. That's marble walking. Plantar fasciitis is when the fascia down here is itis, is inflamed, and it's like it feels like marble walking. But then we also have a bone in the back. What's that called? What's the heel bone called? Calcaneus. And the calcaneus, back to Shamim, the shin stuff that's tight. This bone often goes inward like that. If you just sprained your ankle once or twice, this bone is probably inward. The older we get, this bone gets more inward bent. And then all this gets stiff. If I straighten this bone out on people, it's amazing how much better the leg stuff gets. And it's so safe to do it. It's amazing how easy it is to do it. I would love to show you guys, but if you're really interested. But that's the calcaneus, and that has a lot to do with shin splints too and stuff like that. All right, good. Let's make sure I have all the pictures taken care of. Are these helpful to look at them visually and kind of get an idea? Good, good. 'Cause I want to be somewhat clinical. This I put in because if somebody has plantar fasciitis, that's a metatarsal pad. That's very good. Pushes it up. Helped me greatly. One of those was good. All right, good. So now let's see what we should do here. What's the timing? Good.